main problem is us. I think that people are willing to talk about end of life, but that we are not willing to have that conversation with them.
The fundamental problem is that a lot of the interventions that we commonly use in medicine have been developed on a single issue or a single problem or a single disease. And when we have multiple diseases, multiple problems, frailty, loss of physiological reserve, those interventions don't necessarily work.
And I think patients have a very falsely high expectation of the success of resuscitation and not really aware of the harms that it can also do.
At the moment, there's probably a lack of consistency and a lack of across-the-board consistency with how consultants approach these discussions and conversations.
I don't think the medical profession have been well educated in the past on making decisions. It's a much more comfortable position to do everything than to do nothing.
We always do everything. People say we want you to do everything. We always do everything. Everything looks different for different people. So everything may include intensive care and ventilation, or everything may include a palliative care consult and active palliative care, but we never do nothing.
Managing uncertainty towards the end of life is really difficult. Sometimes it can be clear-cut and everybody is on the same page, they understand where we're going, but other times the medical staff are uncertain about what's happening and they're not quite sure what the patient's expectations are, nor the family.
Doctors and clinicians struggle with conversations, particularly these difficult ones.
Hi, Mrs. Roberts. Yeah, my name's Nick. I'm one of the consultants. I just wanted to have a quick... Oh, thank you, yeah. Do you mind if I grab a seat and we just have a quick chat? Look, you're really not well at the moment, and there's something I need to ask you. Is if your heart stops, are you wanting us to start it up again?
Of course I do. Of course I do. Yeah.
Well, the trouble is it probably wouldn't make any difference. I don't think we'd be able to get it started.
Well, that's nice. Well, you'd have to try, surely.
Well, we could do, but it might put you through unnecessary suffering, so I wouldn't want to do that to you.
Well, how will you know? I mean, what about my family?
Yeah, that's a good point. Well, I guess we could get them in and see what they think, but...
Well,
so
yes,
you're wanting us to do it, are you?
Get them in and of course you would try everything, surely.
Okay, we'll keep doing everything we can then and see, see how you go.
This?
Yeah, okay, well, we'll keep going too.
Oh, good. Yeah, of course.
So I think we need to improve our recognition of people who are sick and who are deteriorating to actually step in earlier and prevent their progression to cardiac arrest.
Have we confirmed cardiac arrest?
Yes, we have.
Okay. We carry on 15 to 2. Vicky, can you just man the D-search? Can you just do a rhythm check for us, please?
And I guess having a framework for how to approach it and what we should be looking for and how we should be making these decisions would be really useful.
Okay, can we please do another rhythm check, Vicky?
Compressions continue, everyone else stand clear, oxygen away, charging, top clear, middle clear, bottom clear, I'm clear, hands off compressions.
Okay, we're still in a systole. Can we dump the charge?
Dumped.
And can we continue with CPR? Are you happy you're getting oxygen at the top end?
Yes, I am.
Sarah, can you please give a milligram of adrenaline intravenously, please? Can someone get hold of this lady's notes for me? And can someone also try and find out if the consultant who's looking after her, or one of the registrars, is available to get a bit more information on her? Thanks.
If the doctors have no information, the default will always be to save the life to the best extent possible. But in many and an increasing number of cases, the families are wanting CPR not to be administered if the benefits to quality of life are not likely. It's important that those possible prognoses and the pathways are explained.